I'm Pat Salver, and I'm CEO of the Doctor Weighs In, which is a media company. I have a blog, I have a radio show, we do videos, anything that has to do with telling the story of innovations in healthcare. And it's a really exciting time to be doing that because there are so many innovations, including the innovations of the people on the panel. So before I get started, the last moderator asked everybody what category of work they did. I want to ask a different question, which is, how many people out there are patients? Raise your hand if you're a current patient or a past patient. Oh, we got one. I'm one. Well, that's interesting because we're innovating for patients, and yet most of the people in the room haven't had a patient experience. So I was also going to ask the group, and I'm not sure since there was only one patient, how many people have actually had the experience of on-demand healthcare? Is there anybody out there who's had the experience of on-demand healthcare? Sorry, it's really hard to see, but okay, two people, okay. So I hope that you'll jump in. I'm hoping that this will be more of a conversation, and I want to include the audience in the conversation, so do jump in if you have questions. I'll ask you to come up to the mic in the front because there's a huge light shining in my face, and that's going to be the only mic that I could see. But we really want to involve you in what we're talking about as well. So I'm going to have my panelists, my esteemed panelists, introduce themselves. And I'm going to start with my old friend, Bettina, and go down the line. And I'm going to ask you to describe what you do, what your company does, and specifically how it relates to this paradigm, the shift away from what I grew up with when I trained as a physician was you had to get in the car and come and see me when I felt like seeing you. And oh, by the way, I might not feel like seeing you at the time that you have your appointment, but that's okay. To really being totally patient-centric and delivering care how you want it, when you want it, and where you want it. Bettina, take it away.
Thank you. And I bet as a former ER doc, how many times did you see patients who were not prepared, rushed to the emergency room, didn't have the information, knew badly needed, and the medication they were on, and so forth. So,
you mean the ones that say, I'm on the little red pill? Lots of times, yes.
Lots of times. So that's all Whatchametrics is about. I'm a physician, became an entrepreneur 25 years ago. I was a health services outcome researcher. And a common sense approach is to put this critical health information, actionable information in the hands of patients so that at the end of the day, you have safer care, better care coordination, and improved safety. So Whatchametrics, my company, which I founded over 15 years ago, deliver mobile health platform for care coordination, patient safety, chronic care management, and we offer those platforms to government programs like state Medicaid agencies, or the NHS in England, or the National Health Program in France. We also offer that technology for license to the life science industry. So here in the midst of bio, our technology is used for clinical trial recruitment, patient safety, adverse event reporting in clinical trial, post-market surveillance. But it's all about putting that critical information in the hands of the patient, locally on their phone, immediately accessible, so they can share as needed on demand the information needed to receive the right care at the right time.
We're going to come back and dive into that because you're doing a lot, you're providing a lot of services in a lot of different areas of healthcare, but I think people are going to want to know, well, exactly how do you get this information in the hands of the patients and the doctors at the right time? So hold on to that. Pamela? Yeah.
My name is Pamela Hudson. I'm a nurse by training. My current position is the Chief Operating Officer for the Center of Digital Health Innovation for the University of California, San Francisco. And what we're focusing on is really twofold. One, about discovery and how we use the digital platform to enhance discovery in regards to accelerating clinical trials, bringing technology to the patients as they enroll in trials, and how to accumulate all that information so we can reduce the cost of trials, speed it up, and bring the information back to the patient so it's actionable to them. The second part, of course, is care delivery. And what I focus on there is the medical devices and working with startups or different companies to validate the devices. And most of it's continuous monitoring types of things like blood pressure, glucose monitoring, those types of things. And then second, once again, is to work with third-party business partners outside to do co-development. We're doing one now, and it's also a speaker today with Cisco for an interoperability platform. And then second, internal development from some of our own physicians in order to improve collaborations between patients. So we just developed a diabetes platform to collaborate with the patients, and then another depression platform for young adolescents, and collaborating with the care provider and the patients and bringing care to them.
Great, thanks. Parag?
Yeah, hi everyone, my name is Parag Uvesh. I'm with Athena Health, and specifically the division in San Francisco that is the Hippocrates division. Hippocrates is a mobile app that's known and loved for many years. It was the 4th app to launch in the Apple App Store, and it's primarily known for being drug reference and disease content. In terms of on-demand and what Athena Health and Hippocrates are aiming for is to connect the dots between the healthcare systems. And if you look at specifically Hippocrates, it's been a one-way street of content being communicated out to physicians in which they can consume and read in a very digestible format, because it's mobile, but also in a very dictionary-style format. And there's very little connectivity to it. So what we're building for is the ability for the physician to have an interactive experience with patient information or other colleagues or information that's personalized to them based on what the promise of what mobile has to offer. So we're aspiring to bring more value to the physician than simply having them type in search terms and provide a result back. We want to elevate the quality of the information they can have, which theoretically would lead to improved quality of care as well.
Great, and we're going to come back to some parts of that as well. But I thought first, Bettina, what I'd like to have you do is describe to us exactly how it is that you get the patient's data in order to make it available to both the patients and then via the patients to the physicians. What is it that you're doing? And you have a hint right here on your lapel.
Thank you so much. Yes, this hint is a blue button logo. I have also a big painting on my back, so when I will leave the podium, you will have a chance to look at it. But it's all about the Blue Button Open Data Initiative, which was launched by President Obama in 2010, and has been, in fact, looked as a model for the NHS to provide access to electronic access to their medical record to all UK citizens by 2018, and the same initiative was just launched in France recently. So the Blue Button Initiative is about giving any American easy access to their electronic health record, and furthermore, in 2014, the new HIPAA rule, part of the Healthcare Reform Act, was to give Americans a legal right to electronically access their health record. And last, part of the Meaningful Use Program, which fueled $30 billion into the EMR industry, this money was distributed upon a requirement on every hospital or provider using this federal incentive money to share record with their patients using specific standards. So we capitalize on this legal environment, legal framework, regulatory environment, so that the patient can automatically receive summary record from their EMR, automatically pull on demand, but easily using a mobile platform, their own claim record from Medicare or Medicaid. And the technology we have developed, which won us 3 awards from HHS in innovating around that program, is to transform that EMR data, that claim data in real time on the mobile device of the patients, so that it becomes an actionable longitudinal record, so that that patient coming to you when you were near practice to say, I am not on a red pill, but I am on so and so medication, and by the way, this may affect my hypertension treatment, as my apps say. So we capitalize on that regulatory framework and the mobile tool in the hands of most of us today. So it's a decentralized, computerized system. Either way, you can deploy it at a large scale. And we have, again, we are deploying that technology with the state of New York, 6 million Medicaid beneficiaries in the region of Sheffield in England, 3 million individuals are going to make use of our emergency app or Tensio app. But it's all about having the data flow via the patients who can then consent to share that information to potentially a life science company and to be recruited in a trial and so forth. But we solve the dilemma of getting that single personal health information directly involving the patient, who can then communicate that information to a provider, a government agency, or life science company.
So just one point that I want to clarify is, so I'm the patient, and I want to have my data, but one of the things about on-demand care, or a lot of care that's not chronic care, is that I'm not thinking about it until I need it, right? So my question to you is, do I have to do anything to get all that data into the app so I can share it?
So the key here is to make that data come to you and not you collect it one at a time, right? And the patient portal way, for instance, through the EMR is not a solution to the problem, because you have to log into multiple portals. That's what people call hyperportalism, another disease. And so when you have like a large payer, when you have a state Medicaid program, who make an app, such as our iBlue button app, available to their entire Medicaid population. And upon opening that app, after you authenticate yourself, that data comes to you automatically. And then we transform that data and make it usable, actionable. So no, you don't want that end user to go through the painful process of one at a time collecting that data. And the value of the payer data, or in a system like the NHS, is that you have centralized system where all that history is there. If you can transform that coded data into something readable, viewable, shareable, the way we do it with mobile technology, then you solve all those practical issues in having that data accessible, flow, and be shared.
Okay, so that's great. So I don't have to do anything, which is what I want. And
pretty much.
So Parag, the question I have for you is, I'm going to look to you to kind of answer the questions of what it's like to be on the receiving end of all this data for, as a physician. I could see that it would be wonderful if I called up and was able to say to the doc, just, here, I've sent you my blue button data, you can see all my health data, and the doc then has it in front of him in order to respond to me. And it sounds like Hippocrates is also kind of doing the thing that our old book, the PDR, used to do when we'd say, oh, excuse me, I'll be back with you in just a second, and then you'd go and look up the drug and come back and say, oh, well, you need to take whatever. So you're making that on demand too. But we hear from physicians, as much as everybody in this room would like to just send all the data to the doctors, what we hear from the doctors is, can't deal with it, don't want it, not going to look at it, don't trust it. What role is your company playing in trying to sort through those issues that are really barriers to having this free flow of information?
Yeah, I think at the end of the day, you obviously can't make anybody do anything they're not going to want to do, right? And so there's certain physicians that don't want the data, and no matter what you put in front of them, they won't use. But there's an emerging class of folks who are using technology and using mobile apps out there in other aspects of their life, whether it's their financial management or their email or planning their outings and so on, that are starting to expect that out of the healthcare system that they would get that same level of technology sophistication. And those are the folks that we're catering to and saying, if we can put information at their fingertips that they trust, that it's coming from validated sources, in our case at Hippocrates, it's from physicians that are writing the content or preparing that content, or it's coming from the aggregate base of Athena Health data that represents about 40 million patients across the US as a sample size, that is reputable and trustworthy information that you can rely on and make decisions based on it. And so that's the promise of what Athena Health offers, is we're taking this information, packaging it up in a digestible way, marrying it with the drug and reference content information that you've always known from Hippocrates, and allowing for the person to make the right decision at the right time. It may be considered overwhelming, right? And we're not suggesting that someone defer to us versus their own intuition. At the end of the day, the physician is on the hook for the success of the patient, and that needs to always be preserved and maintained. But we want to make information available so they can see more patients, make more money. They can provide better care to the patient because of the insights and data that we're offering. Therefore, the patient is happier and has a greater longevity than they would have had previously. Those are the problems that we're trying to solve for, and we feel data is a great answer to that problem.
So Pam, I'm going to ask you a completely different question because data's a part of it. I certainly want my doc to have my data in front of them, and I want my doc to have his decision support that I don't necessarily have to see, but to know that he's going to get to the right information, the clinical information. But there's another component to on-demand care, and that is actually care delivery.
Right.
So talk to me about how patients should make the decisions, or doctors should help patients make the decisions as to how you actually get the care, synchronous, asynchronous, in-person, video, audio, text, whatever. Tell me, your thoughts on that and what you're doing at UCSF.
So I think many organizations are doing what we call telehealth, okay, and that's a personal choice between the physician and the patient. We're also using digital platforms to collaborate with the patient. So right now we're targeting our diabetic population, and they keep their own diary. So they upload all of their glucose readings from their glucometer. They put a diary of their food that they ate that day. They also go ahead and download activities from their Fitbit. And then with all of those pieces of information, we begin to draw a story. And then they have a check-in appointment with their physician or their nurse practitioner in their clinic. And we go through that whole diary with them because it means something to them. And we correlate their diet with their glucose levels, with insulin that was given, and we try to help them moderate so they feel like they're in control of their own health, but they're also collaborating with the physician. For those patients that are inpatients, we actually have telepresence with the patients, so the physicians don't have to go to the bedside. They actually speak to the physician in the patient rooms, either through a telepresence device or through, in some of the new hospitals we just built, we put in a 60-inch TV screen with a monitor and a camera on top, and they actually have a conversation with the physician in their own room, which makes it nice because the physician can be more responsive and not have to go from point A to point B. They can actually go to a device wherever they are and have that conversation with the patient. Last but not least, for our depression patients, we actually created a mobile app, especially for the adolescents, and they put their diary in of what they're doing that day, what they're feeling. And then we created algorithms to monitor, and rather than wait for them to come to us, we actually are predicting that demand, which is what we're really trying to do, and we reach out to that adolescent. If they feel they need to speak directly, they see the status of their providers or their care team to see if they're available to speak right now, or they can send them a text message, or they're out of town. So we give them that flexibility of knowing where that provider is and how they can best reach them. Does that answer your question?
It does, although I want to push back a little bit on your diabetes platform, because just as I asked Bettina about what do I have to do, my own personal experience with keeping diaries and writing stuff and uploading stuff is I do it for a day or two, and then I fall off. And so the question is, are you reaching everyone, or are you only reaching the most motivated people who probably are the ones that are gonna, are already engaged in their care? How does that work for people who aren't engaged in their care?
Then you have to go low tech. So there are people who adopt high tech.
Higher tech.
Yeah.
We'll go about that.
Right, and so what we try to do for those patients who don't adopt the high tech type of approach is more low tech, and it's what we've done so far is we embedded in some of our programs outreach based on algorithms. And so we'll call the patient, and then there's a short survey. They respond back on the phone, really easy, dial 1, 2, 3, based on your response. And then we go through an algorithm and determine whether or not that patient needs a human touch and outreach to them and work with them. So, and then we also have abilities for group visits and going online, getting education programs, those types of things. Sometimes we actually go out and do text messages to remind them to do X, Y, or Z, or if a blood result comes back, they need to have something adjusted, we'll text them on their phone. We're trying to find ways in which a patient can tell us how they want to be communicated to and how they want to be engaged, and try to tailor the program based on what their needs are.
Yeah, that's great. You want to
When I was a
add?
little provocative in saying you can go higher tech, I didn't mean that you are to demand more of that patient or that provider, but you want to capitalize more on what the mobile platform can do. We are, the generation beyond text. So what we do with our chronic care management mobile platform, we automatically receive data from sensor monitoring device, i.e. this home blood pressure monitor device, the blood glucose meter. That data arrives directly to your phone. It doesn't have to transit through a platform. On iOS, for instance, we use Health Kit, so the data doesn't have to be self-entered. It's all entered and displayed and tabulated in the app. Then it goes to the next step. This is about getting meaningful information and direction of what you do with that data. Do you need to call your physician? How do you monitor that blood pressure over time? Does that medication you are taking interfere with your treatment with your physician? So that's where our technology, which is kind of unique, which call it EMR and claim data, put that patient history with their med list, with their diagnosis, into that application, and then we combine that with the sensor data, and we can then notify locally within the app in applying an onboard expert system to say, now, it's time to measure your blood pressure as you wanted to, and here how you do it. And by the way, this medication may interfere with your hypertension treatment. You may want to get the advice from your physician. So we use all that technology, this type of alert, but capitalizing on mobile technology and those iOS or Android platform. So all the data is collated without self-entry, where the algorithm and the notification is happening locally and doesn't have to log into a platform, and where at the end of the day, the physician is less burdened by logging in onto a platform, having a flow of data coming to them. It's a patient who has a more active role, but with more high-tech technology.
Patricia, if I can offer the physician opinion as you asked me to on this, you picked up on an interesting nuance when she said that there's the monitoring by putting it in a diary. That is a form of data in which the physician, who's typically a skeptical individual,
Correct.
Is able to say, do I trust this person's report, or do I trust the Fitbit data, of what actually happened? And so I guarantee you, if asked most patients, how much did they walk yesterday, how much did they eat yesterday, that you'll be off by 30 to 50%, whether positively or negatively. But the Fitbit data is true, provided they had it on them and all that kind of stuff. It gives the reason for the physician to trust everything the patient is saying or not.
That's a very
And then you
important
have a
point.
dialogue with the patient at the same time.
You can learn whether or not they're really in touch with their care plan, or are they passively managing it.
It's unfortunate when you see patient or family caregiver going to the emergency room or for regular care with an Excel spreadsheet of the dozen of medication or half a dozen medication they are on. And typically, the physician may dismiss that information. So again, if you can have in the hands of the patient on their phone, that information coming from a trusted source, your EMR data, or a Medicare claim data turned into a list of meds as we decode it, then the physician can see the source of the data. It comes from Medicare, it comes from that Athena Health EMR of my colleague, and here you overcome that suspicion that this self-entered, self-reported data is not valid.
Well, you're raising a really interesting point. It may be straying just a little bit from on-demand care, but I think it's an important point, and that is this skepticism about self-reported data. Because you mentioned the Fitbit being accurate, but there are actually some lawsuits now. So the question is, what really is the truth? And there are some experiments now going on where patients have access to their records, as they do with your app, and they're able to actually make changes and correct mistakes that were made in their record. And I'm going to give you a personal example. I got taken to the ER. I'm a Kaiser member, so my entire record was, since I started practicing medicine, was in, they had it. And yet when I was discharged, there was a sheet of paper. They gave me pamphlet with all these printouts. It was really lovely. But there was a sheet of paper telling me how I could go about quit smoking. And then about 5 days later, I got a survey to fill out that asked me if the doctor had advised me to quit smoking. So obviously
Right.
somewhere along the line, there was a mistake. I've never smoked, and there was a mistake in my medical record. And so the question is, when we're getting to data and we're trying to get to truth, is it really that self-report is bad and things that come from gizmos and gadgets is good? Or do we actually need to look at this as a much more fluid interaction between the patient and
the
other
physician,
sources?
right, and have a conversation.
And are you doing that at UC? Are you using open notes, for example?
We are using open notes and having those dialogues, but as Parag said, it really is to the individual practitioner and their level of comfort. But ideally, you can't rely upon technology for everything. It really is still a human interaction and a human dialogue. And some patients you'll trust more about what they do, and other patients you're going to query more about it.
So Pat, you're still the exception in having at your care only at Kaiser and for a lifetime, right? Most of us, most of Americans are receiving care in a very fragmented system. So any one of those providers is unlikely to have the total picture of that given patient. If you take a Medicare beneficiary, on average, they see 7 different physicians in 4 different settings, 2 primary care providers, 4 specialists. The likelihood that any one of those providers will have the full picture is cannot be expected. So this is a critical play where the patient indeed can partner with that physician in bringing to them that data they are missing. And in fact, there have been studies showing that when you give patients a right to access and view their records, 1/3 of them find errors in their records. And furthermore, we are still facing a very uninteroperable system. So the key word, is trying to make the system interoperable. It's not. And only relying on physicians to communicate with each other when, in fact, they don't have the time or the means to do that. You want the patient to step in and be a true partner there. With the new value-based care and the MACRA rules, in fact, HHS had a request for information on how to try to address this lack of interoperability issues. And 2 days ago, the Consumer Partnership for eHealth, which include AARP, Consumer Union, American Cancer Society, and a dozen of various patient-facing organizations, reminded HHS that the patient, the consumer, can be this agent of interoperability. They have a legal right and the tool to access their data. They can bring that data to their physician. From a patient safety point of view, as well as from a true value-based care point of view, the patient is going rogue here with the technology we can put in their hands to truly address the real problems we have in our society for healthcare.
And I think that's what will move the industry forward.
Yes.
Is when you have consumers who are demanding better quality care, better insights, faster information, whatever it is that you get in every other industry, that is what they should be expecting out of healthcare.
But they have to own their care. That's probably the biggest driver, is owning that care and changing the paradigm shift where the physician was God or goddess, depending on gender, but that is my care or my child's care or my parents' care. It's really empowering them.
And Parag, you come from outside healthcare, and I think that was a very smart move of Athena Health to bring you on board. Because you have to think different. And Athena Health a few years ago was the first EMR company who capitalized on the web, right, to deliver that EMR functionality in a more convivial way for the physician. And we have to have a different view, and that view has to be driven by that patient who is demanding better, who is demanding the care they want at the right time. They are demanding for the drug which has true value, right? And only the consumer with actionable information in their hand and intelligent tool can drive that system change, I believe.
Yeah, that's been my observation, having been in this industry 6 months, is the amount of information that's blind to the patient is appalling relative to other consumer standards. So if I was going for a routine dental appointment or a checkup, a physical, and I want to know how much it would cost me. That is not something that someone can tell me prior to going in. I can't shop around for different physicians and the price point. I need that transparency, and it doesn't exist. Right?
I have another issue that I want to touch upon, but I just want to see, does anybody have any questions? If you do, please come up to the mic and kind of make a little bit of noise so I know you're out there. The other question that I want to ask, and it fits into all of this, but it's a piece of data and information about me as a patient that I think by and large is missing from most healthcare interactions, and that is my personal preferences and my lifestyle, who I am as a person. And as we are learning more and more about the impact that these things have on the expression of our genome, right? So we're actually bringing it back from what happens in the home and my life into actually what's happening in my body. It's going to become more and more important. And so my question, I think, to all three of you is, what are you doing in that realm to allow patients to self-report or families to self-report that information that may be really, really important about my care going forward? And Pamela, you're shaking your head. I'll start with you.
So I think what we're trying to do, rather than respond to demand, is anticipate demand by starting to do some studies on larger populations, what we'll call omes. So it's your genomes, your biomes, which is your environment, enviromes, and your social history, and mull all that data together to predict and forecast what could be happening to this patient. So the first foray that we're starting in right now has to do with breast cancer and anticipating based on family history, your social economic, your environment you're in, your current health status, what the probability of you actually having breast cancer, and then how to intervene sooner than later. The second would be our target for public health is to anticipate for the first 1,000 days of a child's life based on all those environmental, health, and genomic issues, what the outcome could be for that child, and intervene sooner. So we're trying to forecast demand of care before they actually need that care and intervene sooner by taking all that data that you're talking about and seeing how we can do the models and predict.
So I think that I will take the example of the pharma industry and what we do for them as they are coming to the digital age, engaging the patient to have a direct line of communication. In the old paradigm for clinical trial, you rely on research sites, which will in an ad hoc way recruit patients on an information set which is limited to their system. And then you go through questionnaire for inclusion, exclusion to enroll that individual patient to a trial. And then as you monitor that trial, you rely on this questionnaire and the patient coming back to that research site. In the new paradigm, where the patient has a more active role, that patient is using an app like iBlueButton. iBlueButton collects my history. I may be, with a variation on iBlueButton we provide to pharma, we run an algorithm locally on the app with those inclusion-exclusion criteria to present to that individual patient the opportunity of enrolling to clinical trial A, B, or C. Upon their choice and their consent, they would. And then upon their consent, as they experience treatment, they are more likely to adhere to the protocol of the trial because there is this direct line of communication between the drug company and the patient enrolled in the trial. They can share their information and their experience with treatment, with their various encounters, with their experiencing potential side effects and potential adverse reaction with the drug or other drug in impairing that treatment. For patient safety purposes, the patient is armed with a tool which can immediately notify the clinical trial director that there is an adverse event at play potentially here. So, the patient is not a passive actor any longer. The patient is, as with intelligent tool, a legal right to access their data, can now take a really active role into their care, whether it's a simple event or it's a more complex event in the journey of a cancer patient, for instance.
Yeah, great.
You know, Athena Health is one of the only cloud-based networked software technology products that are out there. And because we represent about 10% market share of the US population, there's about 35 to 40 million people who are in our network data. That presents, to your question, the opportunity for a patient to resemble one of those 40 million people. And so if you look at attributes like a certain age, a certain origin of geography, maybe they're a smoker or not, there's somebody in our system who resembles that, and probably a large swath of people who do. And so for the physician to get insights from this network of data allows them to provide better care for that particular person. So just this week, we launched AthenaInsights.com, which represents data and insights from this 40 million patient base of data that's available. And so we're starting to provide more and more information out to the physicians to be able to look at it on the basis of how does this affect my patient base. We're able to do things like predict the flu trends a matter of days or weeks before it's taken wide effect, right? You can only do that when you have a networked product that's a large sample size of the population.
All right. Well, I want to thank all of you. The time just flew by. Wonderful insights. And let's give our panel a hand.